in eye care, clinicians have to start going out of their clinics and finding out why patients are not coming into their clinics. The objectives of the session are, one, to understand the concept of screening in relation to detection of childhood eye diseases. I'll also try to define the characteristic of a model screening program for children, to understand the basic methodologies, merits and demerits of commonly employed screening strategies, and to share our experiences and learning from community-based childhood eye projects, mainly limited to North India. And this should help all individuals or organizations who are in the process of either initiating or strengthening of their community-based pediatric eye care projects in any part of the country. Now, screening per se in public health has a very specific definition. It denotes the anticipated identification of those who may have a problem and who might benefit from further investigation and treatment. Although in the context of the topic that we are discussing, not all programs strictly fit in this definition. In some cases, the disease may be quite advanced, but we still need to identify those children. And also, not all places we have a validated screening test. So for the purpose of this presentation, the screening word typically implies case finding or detection. So what do we screen for in children? Particularly all causes which are potentially sight-threatening: childhood cataract, refractive errors, amblyoppias of all causes, vitamin A deficiency, retinopathy of prematurity, or any other disorders like genetic disorders, tumors like retinoblastoma can be screened for. But why do we do pediatric screening or pediatric eye screening? As the previous speaker explained, it's an important public health issue. But I would like to highlight three more facts here, that it is not just the pediatric eye health that it improves, it is also linked to the Millennium Development Goals for improving the childhood survival, and also education for all, because if the eyesight is not good, we can't even think about education for all. And also in a long-term poverty elevation. So not just eye health for children, also to a development of the society, it's very important. What is the problem with screening children? There is low prevalence, so it is not like we'll conduct a camp and there will be 30 children walking in. Lack of awareness, so parents will not bring your children to your clinics automatically. Highly skilled manpower is needed, so not a routine technician can screen for pediatric cases. There is a social stigma attached to a child who is blind or whose vision is impaired, so the parents will not bring forth that child. And also there is a lack of service provider, so we need to, the link between service and screening is not there. What is the characteristic of an ideal case finding methodology? One, it should be low cost with high yield, so it should be cost effective. It must identify, or at least attempt to identify, all the cases of childhood blindness in that community. There should be community involvement. There should be a component of health awareness regarding childhood eye health. It should be linked with service provision, and preferably it should be linked with existing health systems prevailing in that region, and preferably it should be self-sustainable. There are various methods of community-based case-finding methodologies that have been described in literature, and various researchers have tried and tested them for various methodologies. So I'll try to describe the salient aspects of a few of them. Also, the choice of which methodology you pick up for your program will depend on the purpose of the screening, whether you're looking for a generic eye screening or you're looking at a specific disease or specific age group. Organizational capacity and resources, depending on what your organization is willing to do for it. The geographical factors, depending on which kind of terrain are you working in. The demography in terms of population density and composition of the population, and also service availability in the region. The first and the most commonly used one is community-based screening, or the door-to-door screening as we describe it. So ideally what is done is we select the geography, we enumerate all the children in that locality, we do home screening for preliminary identification of children, we do a detailed diagnostic screening, identification of children who actually need intervention, and these are then referred to the hospital for treatment. As an experience, we tried it in a region in Alwar, Rajasthan, wherein almost 1,54,000 children were screened, out of which 2,100 children were given spectacles, 1,400 were provided with sight restoring surgeries, and almost 34,000 required medical intervention. So what I am highlighting here is that the merits are definitely covers the entire population at the region, and there is a high possibility of identifying all cases. But the demerits are it has a very low yield when you go into the community directly. It's extremely expensive because you have to go door to door. It needs trained manpower in the field all the time. There are high dropout rates because the community may not come back to your clinic. There is no community engagement. You go as an outsider, and also there is no component of health awareness. And in long term, these processes may not be sustainable. Another option is to go to blind schools. We enlist blind schools in a particular region. We contact the schools for demographics data, how many children are there, what is the age profile. We visit the school with a screening team, which consists of a pediatric ophthalmologist, an optometrist, a low vision specialist, and a rehab counselor. The idea is to examine all blind children in that school and to identify the children who may benefit from low vision aid or surgery. We tried this in Western and Central Uttar Pradesh, where almost 32 blind schools were screened, in which we found out almost that 121 children could be helped with low vision aids and almost 119 could be helped with surgical interventions. But it's again not perfect. The merits definitely are that larger number of children with visual impairment can be screened at one time, and also it usually needs a single team and relatively less expensive compared to other methods. The demerits are that it usually will miss out younger children, girls and other multiple disability children which are usually not present in the blind schools. The difficult logistics are there, traveling to these centers, staying for 1 or 2 days. There is usually resistance from family and the blind school itself if they realize that we are trying to rehabilitate the children and pull them out of the blind school and integrate into the society. And often the intervention is delayed because the children have been there for quite some time, so there is delayed intervention and there is no component of health awareness. Another similar strategy is linking it with CBR projects. Now CBR is a term that is used for community-based rehabilitation, which is a form in which active screening for people with disabilities is done in the community, and early detection and treatment of health condition is done with a health survey, and also the other components like providing medical intervention and other inclusive development strategies like education, livelihood, empowerment, social inclusion is done. As a part of this project, visual impairment screening for children can be done and clubbed with visual rehabilitation and other methodologies of rehabilitation. But again, the problems are that it usually limited to one particular geography. There is social stigma because it is usually associated with disability, and parents again don't want their children to be associated with that. CBR workers may not be highly skilled, they may not be trained enough to identify children with specific causes, so they may be false negatives. And also delayed presentation may still be an issue. But some community engagement is usually planned, so it is done with local volunteers, so community engagement angle is there, and it's a component of ongoing activity, so logistically it is an easier method. A new method which has been developed, not new but new for eye care, is called key informant method. It is developed by one of my seniors at London School of Hygiene and Tropical Medicine. So it's an effective method which involves community engagement, and it's a participatory method. Usually it is helpful to identify children who are blind in low and middle income settings. The utility is that it not only identifies the children, but it is also a rough estimate of the magnitude and causes of blindness in that particular community. The key person in that is the key informant. These are usually members of community who are reliable and willing to contribute their time voluntarily and have an opportunity to disseminate information to a large number of community members, either directly or indirectly. They can be anyone. They can be health workers, school teachers, NGO staff, government staff, traditional healers, local journalists who can be motivated to become key informants. After identification, they are given a specific training, which is ideally around 1 to 2 days, and then they go into the community and try to identify or spread awareness about childhood blindness in the routine work. Followed by which specific eye examination activities conducted, wherein all these identified children are brought, identified and diagnosed, and then referred for follow-up and medical care to the medical facility. It has been successfully used in various settings in Bangladesh, Malawi, Iran, and not just for visual impairment, other disabilities also, and it is being tried in a couple of centers in India also. The advantage of this being that it has an inbuilt component of community engagement. It can screen large regions. It is relatively low cost, and because we are involving community people, long-term sustainability is there. But there are challenges that the entire project is dependent on the dedication of key informants and how we select them. There is a need for training, and so we require region-specific training material. There is high incidence of false positive because these are not skilled trained manpower, and it needs detailed social mapping of the region to identify these key informants. Based on these, we have developed our own program, which is an awareness-linked screening program. The basis of this was that the lack of awareness and local misconceptions relating to childhood eye health are still the most important barrier to uptake of services. So we thought that the solution is to bring about a positive change in attitude and practices related to childhood eye health amongst all stakeholders involved in the health of a child. The components of this pediatric eye health awareness initiative are targeted health awareness, community engagement, along with active screening, and of course a component of service provision. By targeted health awareness, we mean that scientifically developed, simplistic, cultural sensitive IC material is developed based on the problems in that region, preferably using the same people. It needs to be field tested and locally adapted so that the message that we want them to give gets across and it is delivered in the local language. By community engagement, we mean engagement of all stakeholders, be it parents, community leaders, health workers, teachers, and sometimes even the children. We did this for over a year in limited geography, and we were able to screen almost 31,000 children and delivered care to 368 children in form of spectacles and 29 surgeries. And also because, on the other hand, we did a lot of awareness. Now these 1,400 people who have been made aware become our ambassadors. And in the long term, we imagine that the targeted health awareness would lead to self-reporting, and community engagement would lead to community referrals, and need for active screening will be replaced by positive health-seeking behavior. So to wrap up, the take-home messages for a screening program would be that you need to plan it according to your local requirements. Health promotion is an essential component. Community engagement of all stakeholders is essential, and you have to link it with service providers so that the children identified get some care, and long-term self-sustainability needs to be thought of while providing any screening program. Thank you.